My name is Lucy McBride, primary care doctor in Washington, D.C. This is my unscripted, unedited, live show where I talk with experts like my friend Shira Doron about topics du jour. Right now, in the news, the CDC is being gutted. We're on the eve of flu and COVID and other virus season. Public health is in disarray. And people are confused and anxious. Patients are calling me, what do I do? How do I protect myself and my family this winter? So, Shira, thank you for joining me today to help me make sense of the chaos.
You're very welcome. And I hate to tell you, but I'm not sure we're going to make a lot of sense of this chaos today because there are a lot of questions that are not answerable.
Well, one thing I love about you is that you're a realist and you're not going to give people false promises, which is a good segue into the conversation about the COVID vaccine landscape. So, right now, we're awaiting the meeting of the new ACIP advisory committee, the advisory committee that makes recommendations to the CDC on vaccines. For people who don't know, the FDA has already given its rubber stamp for the COVID vaccine for this coming season, but only for restricted groups. So only for high-risk individuals, people ages 65 and above. And they went against prior recommendations that it should be available to all, and they actually sort of suggested it shouldn't be available for kids and pregnant women. So my understanding is that Susan Menarez was ousted from the CDC out of protest. She was standing her ground, trying to not rubber stamp those recommendations. 3 senior CDC officials left in protest. And the ACIP advisory committee has not yet met. And so my understanding is that RFK Jr. kind of slashed and burned that group. And where are we now with the sort of situation? When are the new COVID shots going to come out? Like who's the arbiter of who's the decision maker?
Yeah. And that is the million-dollar question. Where are we now? Where are we going? And who's going to make the decisions? And what are those decisions going to be? And can we change some of the laws to put those decisions into the right hands? So today, we have a situation where the FDA has approved the new formulation. Now, even in normal times, we would probably have a period right now where the old formulation is actually no longer FDA approved because the new formulation is. And there was a time right around now, last year, when actually you couldn't get a COVID vaccine at the CVS or Walgreens either because there's a changeover period. That's normal. The problem is now that the big retail pharmacies in many states are saying, even when we order and even when we get the new vaccine in, we're not going to be able to administer it the way we could this time last year when FDA approved the new formulation, because normally, as soon as FDA approves the new formulation, ACIP, that advisory committee to the CDC, is right on their heels making a recommendation for the winter season. The CDC director rubber stamps that, and we're off and running at the retail pharmacies. This year, that meeting isn't scheduled until later in September, so it's not happening right away. We have a new ACIP. The old one was gutted completely. All 17 members ousted all at once. New committee is actually not even fully formed yet. There's no CDC director to approve their recommendations. And some retail pharmacies like CVS saying, we actually aren't allowed to give anything that isn't recommended by ACIP, so we can't give anything. Or maybe you have to have a prescription from your doctor, which is, of course, a barrier to access. And doctors don't know what they're supposed to be recommending. So here's something that's getting very little attention. And when I try to mention it to reporters who call me about this question, they're not interested in reporting on it. But I think it's really important. Maybe some people will find it reassuring. Maybe some people will find it upsetting. The old ACIP, the one that served under the Biden administration, they were supposed to meet in February. You may remember, big headline, RFK Jr. took over as secretary and the ACIP meeting was postponed. Well, they did meet. The old ACIP did meet in April, and they spent a very substantial proportion of that meeting talking about the COVID vaccine and preparing to vote on a major shift in vaccine recommendation at the meeting that was to be held in June. By the time that meeting came around, new members, the COVID vaccines weren't even on the agenda. But what they reported at the April meeting was that they had been convening their COVID vaccine working group since November. And they were very seriously talking about changing the recommendations for annual vaccination, moving away from annual vaccines for everyone over the age of 6 months and moving toward a risk-based strategy that looks not
Interesting.
that different from actually what's being discussed right now and what's been approved right now. So people over 65 and those with risk factors. Now those risk factors do include pregnancy. You know, based on all the evidence, and certainly that was probably, presumably going to be the plan of the old ACIP. They actually even revealed what their internal voting had suggested, which was that 76% were going to vote for risk-based annual vaccination. Had they allowed this process to play out, had that ACIP been allowed to continue in their duties, had they met in June as scheduled, had they voted on that type of strategy, and one of the reasons they discussed it so seriously is the U.S. is an outlier in the way we recommend the vaccine to everyone, regardless of risk, every year, is we probably would see something pretty similar to what we have now. We would have addressed that issue of public trust that a lot of people have suggested are very blanket, heavy-handed recommendations are having a negative impact on, but we would have not lost the trust of the medical and scientific community, which is what's happening now.
This is a super, super interesting point that I'm surprised and not surprised, Shira, that the reporters who are calling you don't want to report on. Because basically, if I'm hearing you correctly, what you're saying is that the ACIP, the former ACIP, the committee that advises the CDC, that was convened under Biden.
Yes.
And that was gutted by RFK.
Right.
Was, and even did get close to, going to recommend risk-based vaccination schedules that look a lot like what we're seeing today. So that's like a big story. It's shocking and not shocking at the same time that the reporters don't want to report on that. Let me ask you this. Do you think that former ACIP committee was going to, I mean, you don't know, but were they going, because what I'm getting at right now is that it sounds like people who are lower risk for severe disease are not going to be allowed to get the vaccine, the new vaccine. Do you think the old ACIP committee was intended to say, look, here's who's at highest risk, here's who's at lower risk, choose your own adventure based on what we know? Because right now, what it feels like is it's restrictive and punitive for people who are low risk. You and I think, agree that in general, people who are healthy and don't have any underlying health conditions and who are young, the data are clear that people aren't necessarily going to benefit that much from the COVID shot. I still don't think that they should be restricted from getting the shot if they want to get the shot. I'm just not going to die on the hill of people getting a vaccine that they don't absolutely need.
Right. I do think that it is highly likely that had the ACIP had the opportunity to vote, they would have made a recommendation for risk-based strategy with a permissive allowance for people who want to get the vaccine to get the vaccine. Now, the other important point is that when you look at the risk factors, if you go to the FDA's current approval process, where they say that the vaccine is approved for people over 65 with one risk factor, and their long-term strategy is going to be to do clinical trials at people of more standard risk. When you look at any list of what those risk factors are, they really encompass the vast majority of Americans. So I do think that most people, are probably going to be able to get a vaccine. I think there are going to be ways to get vaccine for anybody. I hope, again, with a doctor's prescription, which is not a great thing to require, or with changes to the laws to allow CVS, Walgreens to administer without an ACIP approval. Um, the professional societies are all coming together and putting out their own guidelines. State health departments are coming together and putting out their own guidelines. And I think the retail pharmacies will catch up in terms of being allowed to use those guidelines to administer the vaccine. But even if they couldn't, in the worst case scenario, if it was really restrictive, most Americans have those risk factors. Those are things like having a sedentary lifestyle, ever smoking, um, you know, anxiety, ADHD, really common conditions are still on that list. Now, do I really think that those are strong risk factors for severe disease? Not today, not with widespread immunity from everyone in America having had multiple infections and vaccinations. But that's the list now. It isn't very restrictive.
So you're saying from a practical standpoint, whether or not you have like the really important risk factors like being elderly, frail, immunocompromised, having sort of COPD or some underlying heart, lung, kidney condition,
Who
from a
definitely
practical
should get it.
who should get it. From a
Yeah.
practical standpoint, you think most people will be able to get it.
We'll be able to get it. And remember
Yes.
how it was rolled out at retail pharmacies way back in 2021, but by risk factors. And you didn't have to bring your medical records to the pharmacy. You
Right.
had to attend.
It was self-attestation. I can't imagine. I mean, who knows, right? The world
I
is
can't
changing.
imagine they're going
I
to start
can't
asking for
imagine they're gonna start asking for medical records at the
exact.
pharmacy as the line is going around the sort of Tylenol aisle.
Now your insurance company has access to your medical records. So the coverage of it might be affected by whether you actually have the risk factors, but
Right.
probably not your overall access to it.
To me, I wonder what you think about this. It feels like the headline is that it's becoming, once again, political football. Like the virus does not vote Republican or Democratic. The virus is most likely to impair and impact and potentially be life-threatening for a cohort of patients we've known about since 2020. So, once again, this seems like a failure in the purported rebuilding of trust in public health institutions. Just as you said, if the ACIP had been allowed to vote, probably in a similar way to what the ACIP may vote for this month, that would have done a lot of good. Of course, there would have been controversy, right? But it's just a shame that we are burning down these institutions and burning precious trust. I think it's widely known that since the pandemic, already feeble trust in public health institutions and medical doctors got even worse. So people don't know who to trust. It's the Wild West.
And the irony here is that this is a backlash against a CDC that was being accused of being politically motivated during the pandemic. And, you could say a lot about the way the CDC handled the pandemic. And no one is free from political influence, certainly if you work for the federal government. But as much as I didn't agree with a lot of what the CDC did, I never doubted that the people who worked there were experienced, smart scientists, that they were career public servants, that they wanted to do the right thing for public health, that they were free of financial conflict of interest. I mean, you could sort of say that, maybe they had aspirations to make money from a pharmaceutical company in the future, but I think that's a stretch. They're good people. Um, and trust was lost during the pandemic. But the solution to that is reform at the CDC and reform of public health institutions, not slashing and burning the entire organization that we absolutely depend on for for the health of this country. We could have a crisis tomorrow, whether it be uh, avian influenza, a new COVID variant, or disease X. Um, and with the leaders walking out the door, we are not going to be prepared.
Right. Trust is such an interesting topic. I think you're right that this moment in time is a backlash against what we saw during the pandemic, which we could talk about all day long. You and I have talked about all day long in the past. But I agree with you. There was a sense of the mission was there from the beginning. The integrity was there. Whether we agreed with everything that happened, that's up for debate. Um, but I was really interested listening to a podcast. It was the Dimitri, the like the number 2 at CDC who left in
Galakis.
protest.
Yep.
Yes.
Los Galakis.
It was a really, really great interview he gave for the New York Times, The Daily. And I loved the moment. I don't know if you listened to it, but he talked about trust.
Mhm.
And he talked about the importance of trust in public health institutions and how we have to earn people's trust. And he talked about how the way they tried, he under Susan Monterez or before her, he and the CDC under Trump tried to help, and he's clearly a left-leaning person, you can tell, tried to build back trust was when there was this outbreak of measles in Texas. He went down there and listened to people talk, listened to pharmacists talk, listened to doctors talk about why people weren't getting vaccinated. And I thought this is such an important point. And he said that people told him that they were sick and tired of being told, get vaccinated, get vaccinated, get vaccinated, get vaccinated, without understanding what is the measles? What are the symptoms of the measles? What should I look at for my child? If you have an hour drive to the closest, hospital in Lubbock, Texas, you want to know those things and put in that messaging when you're talking to those people about, information and facts. You put in the information about the vaccine, but you don't hit them over the head with it, right? It's like sneaking broccoli into the sort of the kids' like dinner, right? But my point is that you meet people where they are. So in the same way, I do think the CDC was heavy-handed in its messaging. I think it wasn't ill-intended. I actually don't. People can disagree. My friends disagree with me on that.
Yep.
It was heavy-handed. It was like, get vaccinated or bust. Get vaccinated, get a beer. Get vaccinated, get a cupcake. People were like, that doesn't make sense. That's not healthy. And like, tell me about my risk. I see my friends. They're young and healthy. They're not getting that sick. So people were accused of being anti-vax. I think we are seeing the backlash against that, but it's absolutely inappropriate, as you and I agreed, to burn down public health as we know it. Reform is good. Slash and burn is not. So, Shira, you are the head of infection control at Tufts. You're the hospital epidemiologist. What are you recommending to your staff, to doctors, and then doctors, I mean, you're a clinician as well, to people out there about the COVID vaccine when they ask you, should I get it? When should I get it? Should I wait till the new formulation's out? Should I get the current one now? What are you recommending?
For the most part, I mean, even though we are in this summer wavelet,
Yeah.
and we do see a bump pretty much every summer. I mean, the first summer in New England we saw a lull, but essentially, as a country, we see a little bit of a bump every summer, and so there's always this kind of discomfort because Do I get the old formulation of the vaccine that, there's a new one that's better targeted to currently circulating strains? So for the most part, to that question, should I get it right now? I say no. Wait until the new one is available. And there is this break where the new one's not going to be available, and that's okay. Um, I think the dust will settle. I hope the dust will settle in terms of that access question, the insurance coverage question. Can I get it if I don't have a risk factor? I think that we will find a way, the royal we. For example, I feel confident that health authorities in states where CVS is not allowed to give the vaccine without ACIP will change the law so that CVS can give the vaccine based on other guidelines. So we need to wait a little bit, and it's okay to wait a little bit. Of course, vaccine recommendations are going to be black and white. These people should get it. These people don't need to get it. But the reality is that when it comes to the question of should I get it, it isn't a black and white answer.
Right.
The fact is that your benefit from the vaccine increases with your risk from the disease. And that's not a yes or no question. Your risk of severe outcomes from COVID-19 go up incrementally with age, and they go up with the severity of your underlying medical conditions. So the more of those medical conditions you have, the more severe those medical conditions are, and the older you are, the more you stand to benefit from the vaccine. And so that is a conversation that if you are lucky enough to have a primary care doctor like Dr. McBride, you can have with your primary care doctor. And otherwise, it is probably going to be your choice this year, once all of this dust settles and you figure out whether you can get it and whether your insurance will cover it.
Let's talk about the benefits of the vaccine. We agree that the benefits are on a continuum. The degree to which you will benefit depends entirely on the degree to which you are at high risk for severe outcomes. Caveat, there are people who are not at high risk for severe outcomes who get very sick from COVID, and there are people who are at severe risk and do fine. But in general, we're talking about populations, right?
Right.
So, oh my gosh, I just lost my train of thought. It's like 8:00 at night. What were we just talking about, Shira, Doron?
But in terms of who should get the vaccine, I mean, yes,
Oh,
and
I was
that was more true in the beginning of the pandemic, where perfectly healthy people were walking in to the hospital and dying of COVID.
right,
And when it was the first vaccine, and the majority of the population was what we call immune naive, i.e., they hadn't been vaccinated or infected, it was advisable for every single American over the age of 6 months to get the vaccine. It's
right.
the annual vaccination that we don't know. And, the obvious question is, will it prevent me from getting an infection? A little bit, for a little bit of time. So
So
one,
yeah.
so one of the things I recommend to patients or colleagues when they ask me, should I get the vaccine? I'm young and healthy. Well, it's safe. So do you have a big event? Do you have a wedding? Do you have a trip? You could reduce your risk of getting COVID-19 on your family trip to Europe in December. Maybe you want to time it so that you're getting it 2 weeks before that trip. That would be a great time to get it.
That's exactly right. So that's what I was getting at until my brain fritzed out. I sort of think of it in sort of two buckets. Tell me if this is right. There's the benefit of the vaccine against infection at all, like getting any degree of sickness. And then there's the benefit of the vaccine on severe illness. Now, the benefit you will get on your reduction in risk for severe illness, of course, depends on if you're at risk for severe illness in the first place. If your risk for getting severely ill is not high, you're probably not going to benefit that much. But if we're talking about just infection, like getting sick at all with any degree of illness, from a sniffle to a bad cough, flu-like illness, I think we agree that you do get some short-term, imperfect,
Yeah, very imperfect.
boost in your antibody levels that can then help fight the virus. But I think one thing that people don't often understand is that even though we've lived through the pandemic and saw people get vaccinated 4, 5, 6, 7 times and still get COVID, The vaccine is not sterilizing. That doesn't mean it's not worth getting. It just, we have to manage expectations that it's sort of like wearing a raincoat in a rainstorm. You still are going to get wet depending on the quality of the raincoat, i.e., your immune system, and the degree of severity of the storm, like how much virus you inhale. So you can have a lot of shots. You can have a shot and time it to your Christmas vacation, your holiday vacation 2 weeks before, and then someone coughs on you in a room full of COVID and you can still get COVID. Maybe it would take the edge off.
And that was talking about failures and loss of trust. That was one of the big mistakes in scientific messaging by our public health authorities. We got so excited about the clinical trial results, which truly did show 95% efficacy against symptomatic infection,
That was
not
amazing.
just severe disease.
Yeah.
But it didn't last. It didn't last. As soon as a variant emerged that had a little bit of immune escape, it didn't work like that anymore, and the message changed. And so instead of framing it from the beginning as, "Here's a vaccine that's going to protect you from severe disease," it started with, "Here's a vaccine that prevents infection, and you can take your mask off." Um, that shouldn't have been the message at all. You should have been able to take your mask off because you were not going to get severe disease, not because you
Right.
weren't going to get infected.
Right. That's right. Yeah, the Delta variant, the ship kind of sailed with the Delta variant in 2021. The vaccine looked like it was this miracle, and then it wasn't. It just wasn't.
And that's
Uh,
probably when we should have stopped with the vaccine mandates too, because it
I
wasn't
mean,
it wasn't preventing infection anymore, and it wasn't creating that herd immunity anymore.
that's right. Okay, so just to put a finer point on this, not to over-index, but someone just asked a good question about transmission to a higher risk individual in the house. So again, the vaccine does two big things. It helps prevent against infection imperfectly for a short amount of time, starting 2 weeks after the shot, maybe lasting a couple months. And two, it helps prevent against severe disease, which is not that important if you're not at high risk to begin with. But if you're at high risk for severe disease, needing the hospital care, needing oxygen, then you're going to benefit. So people ask then, well, what about, does it help prevent transmission? Does it help prevent giving someone else COVID if I were to get it? Like, in other words, shouldn't I get vaccinated to protect other people? What do you say to that?
If you don't get infected, you won't transmit.
Right.
Um, but the vaccine isn't very good at that. So relying on the vaccine for yourself to protect others is kind of a fool's errand. Um, you protect the high risk people in your household by making sure that if they get sick, they're getting an early test for flu and COVID, because both of those have antivirals that treat them. And that you are using those antivirals because they're highly effective as well, particularly the ones that we have for COVID.
So that's a great point. So you're saying the best way to protect your loved ones, if they're in your household, is to protect them from getting infected, and also staying away from them when you yourself are sick. Right? Like, one of the best acts of love for people in the world is to, when you're sick, stay home. There's no amount of vaccine that I can get that's going to protect me from infecting you, but certainly if it helps me get less sick, that's good, but it's not a force field to help protect other people.
And the COVID vaccine is remarkably good at protecting even immunocompromised people, even very
That's right.
immunocompromised people. And, there was a period when we were doing a lot of COVID antibodies and finding that the antibodies weren't that high in immunocompromised people. Antibodies do not tell the whole story about the efficacy of the COVID vaccine. There's T cell immunity, cellular immunity that is activated even in very immunocompromised transplant recipients. And so they are the people who should be getting the vaccine, not only the annual vaccine, but every 6 months vaccination.
A patient wrote me from the West Coast today to where I am in DC, asking me, she's like, I just went into a doctor out there and got my spike antibody levels tested. I'm like, why would you do that? Why would a doctor? Anyway, I mean, I didn't make her feel bad about it. I just thought to myself that, and she said they're high. So do I need a vaccine? I said, well, first of all, the antibody levels are only one tiny piece of the picture of your immune system. The immune system is wide and vast, and you can't assess it in a single blood test. You have T cell immunity that's under the surface and is robust and protects against severe disease. Secondly, the fact that you have a high spike antibody means either you had COVID or you got a vaccine recently enough. So it was an interesting conversation, but reminded me back in the days of when we used to check spike antibodies and nucleocapsid antibodies to see if people had been exposed to actual COVID.
It's good for research, and
Yeah.
very little else. These antibody studies have told us that essentially every American has had COVID, even if they don't know it. And that is part of, that was a big part of that ACIP conversation that led to them, leaning heavily toward risk based vaccination. That the landscape has changed. Every winter, we see fewer and fewer hospitalizations and deaths due to COVID. We're really seeing that community immunity. Let's not use the word herd immunity. We didn't get there, but that community immunity, that wall of immunity that's protecting against massive waves of severe disease that overwhelm the hospitals. Barring a very different variant, we don't expect to see that anymore.
Yeah. Leslie Bean is asking a great question, as expected. The idea that the protection from the vaccine is so short lived and that one has to time vaccination, for example, right before a trip to get benefit, now, not at first, seems totally different to me. Did we ever use vaccination this way?
No, and many years, influenza vaccination isn't that effective against infection either. But influenza vaccination is different. You really cannot expect even protection against severe disease from one year to the next. Whereas the COVID vaccines have really been durable in terms of that cellular immunity and protection against severe disease. So yeah, I mean, we need better COVID vaccines, and I think that in many ways the Novavax is better than the mRNA vaccines, the Pfizer and Moderna vaccines. When people ask, I do recommend it as a better side effect profile in terms of those, not dangerous but pesky side effects, fever, sore arm, fatigue. Um, it seems to be a bit more variant proof over time and maybe have some more durable protection. So the Novavax is a good option, but we need better COVID vaccines that do prevent infection in a more durable and effective manner.
A couple of topics I want to cover with you now. One is Paxlovid. Two is your thoughts on long COVID. Three is going back to your point you were just making about flu shots versus COVID shots. So, can we start first with Paxlovid? Do you recommend Paxlovid to people? I think we're in a data-free zone where the original studies were done on unvaccinated populations. What do you tell people who have been vaccinated, may have had COVID already, when they get COVID? Should they take Paxlovid?
Yeah, it's the same issue that we have with the vaccines. We don't know exactly who stands to benefit, but Paxlovid, if you're careful with the drug interactions, has been incredibly safe, incredibly safe. And so again, looking at those risk factors, the more risk factors you are, the more you stand to benefit from that Paxlovid. Of course, the more risk factors you are, the more likely you are to be on medications that interact. And we have some other options. But I do use it when I think that person stands to benefit. And where exactly I put that cutoff line, I couldn't tell you. It's not
Yeah,
even.
it's a constellation of, like, I have a patient who's in her 80s who had COVID diagnosed today. We have a PCR machine in our office, and she's had COVID for 5 days, and she's doing really well. And she's got some cardiovascular issues, but so I told her, "I don't think you need Paxlovid. You're already far enough out from the disease onset that your viral replication isn't happening as much." In other words, like, the Paxlovid's superpower is it gets in the machinery of the reproductive cycle of the virus, but if you're already 5 days out, it's not gonna do a whole lot, and so she was comfortable with that. I might prescribe it to someone who we catch COVID, like their symptoms are right that you start that day, we catch it on a test,
Yep.
they have
Earlier
underlying
the better.
conditions, and I start it right away. But it's so nuanced, and I don't think there's a black or white, which is why, of course, everyone needs a primary care doctor, and it's a crying shame that 100 million Americans don't have access to one. But it's also a reason why I think that we should be more permissive in who should be allowed to get it because people just don't have access to individual doctors in this country.
Yeah. 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 And that the test to treat program was really effective.
Yeah.
When, pharmacies could test and then prescribe. Those kinds of programs are really important when people don't have primary care doctors, for sure.
So someone asked me today about long COVID. Okay, what if you're low risk, but you want to get a vaccine because you're worried about long COVID? What do you say to that person?
Well, in the CDC, ACIP meetings, they really do tout heavily the data that suggests that you can reduce the risk of long COVID with vaccination. Um, you know, the problem with all of the data that the CDC that the ACIP presents about vaccine efficacy is it's all, retrospective data um, with, healthy vaccinee effect, meaning, the people who choose to get vaccinated are different than the people who choose not to get vaccinated. They're healthier at baseline. So you have to take it all with a grain of salt. Um, Long COVID is a lot like chronic Lyme, is a lot like, chronic fatigue syndrome from Epstein-Barr virus. There is a biological plausibility to the idea that an infection can cause long-term symptoms that can be debilitating.
Yep.
And it is understandable that people with no risk factors whatsoever, may want to try to avoid that with the vaccine. And I think that the CDC was going in that direction and that was the right direction to go in, a risk-based recommendation with a permissive allowance for people to get the vaccine because it is safe. Now, we know that the big side effect, the big adverse event from the mRNA vaccines, Pfizer and Moderna, was that myocarditis, inflammation of the heart muscle that we saw more in boys than in girls and more in young males than in older female adolescents than in younger boys and older boys. So adolescent males was the real high risk population for that inflammation of the heart muscle. According to the data that the CDC has been sharing during recent meetings, the prevalence of that has gone way down. So that's reassuring because my advice was different back when so many young men were getting myocarditis from the vaccine, often after having had natural infection already, and I really wondered whether it was worth it. Um, so I think, if you are somebody even in that sort of young male age group and you really want to avoid long COVID, I wouldn't say not to get the vaccine. But if you are young and healthy, that benefit is going to be less likely to be achieved than if you are someone who's older and has underlying medical problems.
What do you tell somebody who's looking to get a vaccine, like maybe at the end of the September when the new formulation comes out, but they had COVID within the last 3 months, or they had a vaccine dose within the last 3 months? What do you say in terms of timing the vaccine dose after a last exposure to either virus or vaccine?
Yeah, I mean, I think it's different whether it's virus or vaccine. People who are severely immunocompromised could get a vaccine every 3 months if their doctor recommended that, if their cancer doctor or their the doctor that's taking care of their immunocompromising condition. And it doesn't interfere as much with sort of the maturation of immunity. That's my concern when people get a vaccine too close after their infection, is when you get the infection, your immune system is exposed to the whole virus. And so it's a really robust immune response. And if you give a vaccine while that immunity is maturing, you can actually interfere with the success of that maturation. And so when it comes to getting vaccinated after infection, I recommend 6 months.
Oh, wow, 6 months.
Yeah.
Okay, to let the immune system mature.
Yes, to really develop the response that it's going to have to the whole virus and all aspects of that virus.
What are you recommending? I know you're not a pediatrician, Shira, but um, what do you recommend for kids? Um, what are you telling pregnant women?
Yeah. So the American Academy of Pediatrics did come out with its own guidelines to fill the vacuum that has been left by not having an ACIP recommendation on this issue. And they actually downgraded their recommendations from prior years as well. So they're only strongly recommending vaccination up to the age of 2.
Hmm,
Then over the age of 2, only with risk factors, or if parents
interesting.
want them to. Yes.
That's
So,
the AAP. That's the
eh,
AAP. Wow. That's
yeah,
a big departure.
it's a big departure. It makes a lot of sense because when you look at the data, you see a spike in severe disease at the older extreme of age, and a spike of severe disease at the young extreme of age. Now, a lot of that is under 6 months, not eligible for vaccination anyway. So that's going to play into what I say about pregnant women. But some of that also is, children under 2. Now, we have a very low threshold to hospitalize children under 2, so it's a little hard to tease out, but it does seem like the risks are at the extremes of age, and so they're recommending vaccination really strongly only for those youngest children. Pregnancy is a risk factor. Pregnancy is an immunocompromising condition. It's a risk factor for severe disease. And we know that not only will a vaccine protect you if you're pregnant while you're pregnant, but the antibodies can be passed on to the baby who then won't be eligible for vaccination until 6 months. So for more than one reason, it's a good idea to be vaccinated when you're pregnant.
Super helpful. Our friend David Zweig wrote me this morning saying, "Thanks for your newsletter today." He said a lot of nice things, but they said, "I'm confused about your comment or a little section about the flu shot." In it, I wrote a newsletter this morning about the COVID chaos and CDC, and then I had a little ditty on the flu shot. And I said, in general, I recommend that all of my adult patients get the flu shot because it's safe and effective. And I went on to say some other things. And he said, is it effective? Where's the data to show that it's effective against either infection or severe disease? Can you enlighten me?
Yeah. Um, some years we don't see much efficacy against infection at all. And the effectiveness against severe disease, it changes from year to year. Um, we try to guess what the formulation should be to match what's coming based on what we saw in the southern hemisphere. We don't always get it right, and some years the efficacy, even against severe disease, is very low. And certainly, it's not unusual for that efficacy to be below 50%. Now, that's not zero. A
It's
40%
not
here,
zero.
a 30% here is not zero, and it is a very safe vaccine.
So that's what I was going to write back to David, because it's a really fair question. I've always recommended the flu shot. I always get the flu shot. I think it's always good to remain curious and open to and understand the data. Um, we've always known that the protection against infection from the flu is it varies year to year based on the formulation, and it's not 100% even when the match is good. I mean, patients say to me every year, somebody will say to me, a couple of patients will say, "Every time I get the flu shot, I get the flu," like, as if the flu shot gives them the flu, and I'm like, "Well, no, it's just that the flu shot isn't a force field, doesn't protect you against infection,
Yeah.
but maybe it took the edge off a little bit, maybe not that well." But you're saying just like the COVID shot, there's infection there's protection against infection, which is getting sick to any degree. That is imperfect. And there's protection against severe disease, also imperfect, but not zero.
And I'll personally take just a little bit less horrible because, if you've had influenza
It's awful.
and you weren't vaccinated, which I accidentally did one year when I was a medical resident, I will never make that mistake again. Never, because that feels awful and for a long time. So I will take a slight bit of efficacy any day over getting that badly again. And I haven't gotten it that badly again.
And talk to me about the importance of getting an annual flu shot and how that's different depending on who you are for the COVID shot. Like,
For the
what's the
COVID shot,
difference there?
I mean, we're still learning, but what it appears is that the flu shot from one year to the next won't protect you from getting severe disease, whereas the COVID vaccine has a durable cellular immunity protection against severe disease. I mean, it's not absolute. Obviously, there are people who get multiple COVID vaccines and still end up sick in the hospital. But they are not the same in terms of that sort of durable cellular immunity.
So what I hear you saying is not don't get a COVID shot this fall or annually if you're high risk, but rather that unlike the flu shot, the COVID shot offers protection for more than just that
Right.
1 year against severe disease. So, like, if you got COVID, like my 80-year-old patient who has COVID right now might, quote, "enjoy some protection against severe infection even 2 years, 3 years from
Yep.
now." Unlike if she had the flu right now, next year she'd be not
Yeah.
as immune.
But then, too, the difference between being young and being 80 is that even a mild infection can tip an 80-year-old over into
That's right.
heart failure, kidney failure, dehydration, kidney failure. So, you know, it may be that that effectiveness that we see in the elderly from that annual vaccine isn't so much that they've lost the cellular immunity against severe disease, against that sepsis like syndrome that we saw in 2020. It's that at those extremes of age, even a cold can
Yeah,
become severe disease.
that's right. That's right. Um, Someone's asking here, Shira, I heard from someone recently sick with COVID that the latest variant causes a sore throat that feels like stabbing knives. Um, I mean, it depends. I actually saw a patient who's like 24. She's a student at Georgetown today who has COVID, and she came in saying, "I have strep." She clearly didn't have strep. She had COVID.
Yep.
She felt like the stabbing knives. But I've seen that with other COVID variants. I've also seen
Exactly.
that with the flu, and I've seen that with other viruses.
Yeah. Every time a new variant comes out, first people give it a nickname that we shouldn't give it. They give it usually scary nicknames that come from social media and should not be amplified by the media. And then people attribute new or different symptoms to that variant. And it has never been proven that one variant is more associated with things like sore throat than another variant. Um, if there are epidemiologic differences over time, it's probably more related to immunity. But one person could get sore throat that feels like knives, and another person gets cough, and another person gets a lot of nasal congestion. It just really depends.
Yep. Okay. Bonus question, if you will. RSV. How often should someone get the RSV shot?
We don't know yet. It hasn't been out long enough to know when the immunity from it will wane to the point where they need another one. So we're waiting. We're waiting for those longer term studies.
Thank you. That's what I'm telling my patients. I say get it once. It's not an annual shot,
Nope.
but whether it's every 2 years or 3 years or 5 years, we don't know. Um, a patient of mine had RSV last winter, and she asked me today um, if she still needs the RSV shot. And I said, well, yes, because you're 75 and because you could get seriously ill from RSV, and the immunity you had from last year is not durable. Are we thinking that the RSV shot is therefore more durable? I mean, I'm guessing the answer is yes, and that's why we're not recommending it annually or every 3 months.
Yeah, no, I think it's going to be more durable against infection than the COVID vaccine and then the flu shot. I think it will wane. I think it will wane at 3 or 4 or 5 years, and it will be like a pneumonia shot where we
Yeah,
do it, where we find an interval that makes sense.
that makes sense to me from a biological standpoint. People are asking about COVID testing. I recommend COVID testing for people in whom knowing your diagnosis is going to change management. So someone who's a candidate for Paxlovid, someone who I need to know they have COVID or flu to direct antiviral treatment, which is typically the higher risk patients.
Right.
People often just want to know what they have, right? Like they want a name for the reason they feel horrible. And they want to be able to tell their friends. But as I say to patients all the time, just because you don't have COVID or you don't have flu, like you can't name your virus, doesn't mean you aren't contagious with whatever virus
That could be bad for
that could be
somebody
bad,
who's
right?
immunocompromised. Yeah.
Right?
Yeah.
What do you tell people about testing?
Not a good use of our medical resources if you don't otherwise qualify for treatment, meaning you have risk factors where we think that treatment would help you, but also you're in a window where treatment will help you. So yes, I recommend testing high risk people for COVID and flu.
Yep.
Treatment for flu not so effective usually, but we still give it to those who are high risk. And I really don't recommend RSV testing because there's no treatment.
Yeah.
And it looks like a whole bunch of other viruses, the tests for which are really expensive and really don't change management.
Yep.
And so I really try to discourage those.
I will still recommend, with a lot of caveats, the rapid test, the home antigen test for COVID, because I still remember Michael Mina from the pandemic, that the rapid tests are essentially contagiousness tests. They are not perfect, but they can kind of help you guide when you're no longer contagious. I also tell patients, use the old sort of trick that when you're no longer symptomatic, when you're feeling better and you're fever free for 24 hours without fever reducers, you're probably not contagious. But if you want more specificity and you want to look at that pink line on your home test, go from bright red to pale pink, that probably means you're less contagious. But there's a lot of guesswork here.
Yeah. Yeah. And it wouldn't be, imagine doing that. Imagine if we had a home test for every virus and we did that for every virus. Society would grind to a halt because everybody would be inside waiting for their everything test to turn negative. So, we do have to balance practicality a little bit with, in an ideal world, everyone could stay home for the entire time that they have any contagiousness with any virus whatsoever, but that's not reality.
That's not reality. Um, Shira, thank you so much for joining me. I learned so much, and you're an excellent communicator and excellent translator of complex data. And what I also love about you is you're comfortable not knowing everything. Like, I think that's one of the things we need to be um, comfortable with as clinicians, as public health practitioners, as you are, um,
And that builds
acknowledging
trust.
uncertainty.
Don't you think that builds trust? And that's what we really needed our CDC to do before they lost trust and before we got to the
Yeah,
terrible situation that we're in today.
right. Acknowledging gaps in our knowledge, not because we aren't trying, and allowing people to make decisions based on their understanding of the nuances of risk. Nothing in life is risk free. It's about trade offs, and trade offs are aplenty. So, Shira, thanks for joining me. Stay safe and well this flu season, and I will talk to you soon.
Always a pleasure. Thank
Okay,
you.
bye.
Bye.